Good morning, dear students. Uh, Topic of our lecture is senile asthenia and geriatric palliative care. Senile asthenia is multifactorial syndrome that include various unpleasant manifestations and increased risk of imminent, imminent death. Research into this syndrome is ongoing as the concept of senile asthenia appeared in medical science not so long ago. However, it is already possible to distinguish the syndrome and suggest methods of correction. Senile asthenia has a blurred clinical picture. Relative often attribute behavioral and physical changes to the patient's old age. What are the symptoms of senile asthenia? Digestion difficulties are the first symptoms that appears in patients. Weight loss, such as a decrease in body weight or more than 10% per year. Elderly people start to lose weight pretty fast, despite maintaining their usual diet. Trouble walking. Asthenia also affects the brain. The patient gradually loses memory. There is pronounced absent mindedness. An elderly person suffers from reasonable anxiety, depression, and speech disorders. Along with these symptoms, the patient has chronic insomnia. As a result, the person experiences chronic fatigue. Muscle weakness and low physical activity problem with the musculoskeletal system develop. Coordination of movement is lost. The sense of balance is disturbed, and minimal physical activity leads to fatigue and dizziness. The loss of self-service. Often, the clinical picture includes a sharp decrease in hearing and eyesight. Uh, who is more at risk of developing senile asthenia? There is a high risk of developing severe asthenia, severe or early asthenia in such cases. Women, uh, the older a person is, the more severe asthenia is. About 5 times every 5 years after 65 years. People who don't have a family, people living in small towns and villages, labor workers, people who live in unfavorable social and living conditions and have a low income. Uh, Stage of senile asthenia. In diagnosing asthenia syndrome, it is necessary to distinguish the stage. There are three stages of senile asthenia. Stage 1. The honest onset is characterized by weight loss. If an elderly person loses more than 8 lips per year without dieting and physical activity, this may imply the onset of the syndrome. In addition, you may notice the patient has difficulty walking and a decrease in hearing and eyesight. Stage 2. The elderly person loses the ability to care for themselves and cope with daily routines, memory loss, apathy and depression progress. Often there is urinary incontinence, so the patient may require a deep. At this stage, the patient needs regular care. An elderly per stage 3, an elderly patient cannot get out of bed independently, mental activity deteriorates sharply, a vegetative state gradually develops, and the person can die suddenly. What are the causes of senile asthenia? Senile asthenia occurs against a background of age-related changes in the body. Usually, the pathology develops around 65 to 70 years of age. Biological changes inevitable affect the quality of life. It is difficult for previously active person to come to terms with the new age and the appearance of restriction. In addition, a physiological factors is connected to rapid aging. Elderly people are often limited in social relations, sharply narrowing the circle of contact, and the sense of social significance is lost. Besides, a sedentary lifestyle, poor nutrition, and bad habit negatively affect health and increase risk of senile asthenia. The inability to fully preserve visual and auditory information lead to impaired motor function and cognitive disorders. Senile asthenia develops as a result of concomitant disease such as Alzheimer's disease, Pick's disease, cancer, cardiovascular pathology, and endocrine disorders. Asthenia is a risk in people who experience stroke or suffer from dementia and depression. Taking a considerable number of drugs also contributes to developing the pathology. Geriatric is engaged in the study of asthenic syndrome. First, the doctor examines the patients and collects a detailed anamnesis with questionnaires and functional tests that determine the diagnosis. The one of these questionnaires is the determination of the senile asthenia degree. There are also questions about chronic cardiovascular, endocrine, and central nervous disease. Next, the doctor assesses the patient's physical activity when they perform simple exercise, for example, lifting their torso from a sitting position, a brick walking, standing still for a moderate duration, holding hands in a given position for a particular time, etc. The doctor also assesses wrist power with the help of compression device and estimate the ability to carry out self-surface procedure independently. Since the syndrome often occurs against the background of another disease, a complete medical checkup and consumption and consultation with different specialists are necessary. Based on the results of analysis and physiological testing, the doctor determines the stage of pathology and prescribes therapy. The effects of aging must be taken into account during the diagnosis and treatment of older adults. Clinicians should note mistake pure aging for disease, like slow information retrieval is not dementia, mistake disease for pure aging, ascribe debilitating arthritis, tremor, or dementia to old age, ignore the increased risk of adverse drugs effects on weak limb system distressed by illness, forget that older adults often have multiple underlying disorders like hypertension, diabetes, atherosclerosis that accelerate the potential for harm. Comprehensive geriatric assessment is a dimensional process designed to assess the functional ability, health, physical, cognitive, and mental, and socio-environmental situation of older people. CGA, especially for thoroughly evaluates functional and cognitive abilities, social support, financial status, and environmental factors, as well as physical and mental health. Ideally, a regular examination of older patients incorporates many aspects of CGA, making the two approaches very similar. Assessment results are coupled with sustained individually tailored interventions, rehabilitation, education, counseling, supportive services. Assessment can have the following benefits: improvement care and clinical outcomes, greater diagnostic accuracy, improved functional and mental status, reduced mortality, decreased use of nursing homes and acute care hospitals, greater satisfaction with care. If older patients are relatively healthy, a standard medical evaluation may be appropriate. CGA is most successful when done by a geriatric interdisciplinary team. In many settings, the CGA process relies on a core team consisting of clinician, nurse, and social worker, and when appropriate, drawn upon an extended team of physical and occupational therapists, dietitians, pharmacists, psychiatrists, physio- physiologists, dentists, audiologists, podiatrists, and opticians, psychologists. Usually, assessments are done in an outpatient settings. However, patients with physical or mental impairments and chronically ill patients may require inpatient assessment. Indication for referral. The best evidence for CGA is based on identify appropriate patient, including patients who are either too well or are too sick to derive benefit. No criteria have been validated to readily identify patients who are likely to benefit from CGA. Specific criteria used by CGA programs to identify patients include age, medical comorbidities such as heart failure or cancer, physiological disorders such as depression or isolation. Specific criteria used by CGA program to identify patients include specific geriatric conditions such as dementia, falls, or functional disability, consideration on changes in living situation from independent living to assisted living, nurse homing, or in-home caregivers, previous or predicted high health care utilization. One outpatient approach would be to refer patients for CGA who are found to have problems in multiple areas during geriatric assessment screens. Minor illness, those requiring hospitalization or increased home resources to manage medical and functional needs, should also prompt referral for CGA, particularly for functional status, fall risk, cognitive problem, and mood disorders. In a patient approach would be to refer all the patient admitted to for a specific medical or surgical reason, fractures, recurrent pneumonia, pressure sores. Another approach would be to have all patients above a certain age or above a threshold on instruments predicting hospital readmission receive preliminary screening to determine whether a full multidisciplinary evaluation is needed. Conceptually comprehensive geriatric assessment involves several processes of care that are shared over several provides in the assessment team. The overall care rendered by CGA team providing longitudinal assessment and care can be divided into six steps: data gathering, discussion among the team, increasingly including the patients or caregiver as a member of the team, development with the patient or caregiver of a treatment plan, implementation of the treatment plan, monitor and response to the treatment plan, revision the treatment plan. Although the amount of potentially important information may seem overwhelming, formal assessment tool and shortcuts can reduce this burden of the clinician performing the initial CGA. A pre-visit questionnaire sent to the patients or caregiver prior to the initial assessment can be a time-saving method to gather a large amount of information. This questionnaire can be used to gather information about general history, past medical history, medication, social history, review of systems, as well as gather information specific to CGA such as ability to perform functional tasks and need for assistance, fall history, urinary or fecal incontinence, pain, source of social support, a particular family or friends, depressive symptoms, vision or hearing difficulties. Core components of CGA that should be evaluated during the assessment process as follows: functional capacity, fall risk, cognition, mood, polypharmacy, social support, financial concerns, goals of care, advanced care preferences. Additional components may also include evaluation of the following: nutrition, weight change, urinary continence, sexual function, vision, hearing, dentition, living situation, spirituality. Functional status refers to the ability to perform activities necessary or desirable in daily life. Functional status is directly influenced by health conditions, particularly in the context of an adult's environment and social support network. Changes in functional status, not being able to bathe independently, for example, should prompt further diagnostic evaluation and intervention. Measurement on functional status can be valuable in monitoring response to treatment and can provide prognostic information that assists in long-term care planning. Activity of daily living. An older adult's functional status can be assessed at three levels: basic activity of daily living, instrumental or intermediate activity of daily living, and advanced activity of daily living. Basic activity daily living refers to self-care tasks which include bathing, maintaining continence, toileting, dressing, grooming, feeding, transferring. Instrumental activity daily living refers to the ability to maintain an independent household, which include shopping for grocery, driving or using public transportation, using the telephone, performing housework, doing home repair, repairing meals, doing laundry, taking medication, handling financial finances. Other possible instrumental activity daily living that reflect the increased reliance on technology, which have not been validated, include ability to use a cell phone or smartphone, ability to keep a schedule of activity, ability to use the internet. Advanced uh, advanced active daily living vary considerably from individual to individual. These advanced activities include the ability to fulfill social, community, and family roles, as well as participate in recreational or occupational tasks. Scales that measure functional status at each of these levels have been developed and validated. The Vulnerable Elder Scale is a 13, 13 items screening tool that is based upon age, self-rated health, and the ability to perform functional and physical activity. It identifies a population of community dwelling elders at increased risk for functional decline or death over 5 years period. The Vulnerable Elder Scale 13 can be self-administered or administered by non-medical personnel over the telephone or at an office visit in less than 5 minutes. Because of its brevity, the clinical frailty scale is also used in clinical practice. Adults over age 70 are more likely to have motor vehicle accidents as well as increased associated mortality. The patient's ability and safety to drive a car should also be evaluated in the functional assessment. In addition to measure of activity daily living, gait speed alone predicts functional decline and early mortality in older adults. Assessing gait speed in clinical practice may identify patients who need further evaluation, such as those at increased risk of falls. Additionally, assessing gait speed may help identify frail patients who might not benefit from treatment of chronic asymptomatic disease such as hypertension. For example, elevated blood pressure in individuals aged 65 and older was associated with increased mortality only in individuals with a walking speed uh, more than zero point 0.8 meters in second, measured over 6 meters or 20 feet. Approximately one third of community dwelling person age 65 years and one half of those over 80 years of age fall each year. Patients who have fallen or have a gait or balance problem are at higher risk of having subsequent fall and losing independence. An assessment of fall risk should be integrated into the history and physical examination of all geriatric patients. The incidence of dementia increased with age, particularly among those over 55 years, yet many patients with cognitive impairment remain undiagnosed. The value of making an early diagnosis include the possibility of uncovering treatable conditions and initiating advanced care planning while the person still has capacity to participate in the process. The evaluation of cognitive function can include through history and brief cognition screens. If this raises suspicion for cognitive impairment, additional evaluation is indicated, which may include collateral information gathering detailing mental status, examination, tests to evaluate medical conditions that may contribute to cognitive impairment, um, for example, in case of B12 deficiency, anemia, thyroid stimulating hormone, vitamin B12, thyroid stimulating hormone, depression assessment, and radiographic imaging, computer tomography, or magnetic resonance imaging. Further evaluation in some persons includes neurophysiologic testing. Depressive illness in the elder population is a serious health concern leading to unnecessary suffering, impaired functional status, increased mortality, and excessive use of healthcare resources. Late life depression remains underdiagnosed and inadequately treated. Depression in elder adults may present atypically and may be difficult to assess in patients with cognitive impairment. A two-question screener is easily administered and likely to identify patients at risk of if both questions are answered affirmatively. The questions are: during the past months, have you been bothered by feeling down, depressed, or hopeless? During the past month, have you been bothered by little interest or pleasure or in doing things? This two-question screen is sensitive but not specific. Thus, a positive screen should be supplemented with 7 additional questions to complete the patient's health questionnaire 9. The patient health questionnaire 9 has increasingly been used to detect and monitor depression symptoms among elder adults. The patient health questionnaire 9 provides a reliable and valid measure of depression severity. Older persons are often prescribed multiple medication by different health care providers, putting them at increased risk for drug-drug interaction and adverse drug events. The clinician should review the patient's medication and each visits. The best methods of detecting potential problem with polypharmacy is to have patients bring in all of their medication, prescription and non-prescription, in their bottles. Discre- uh, Discrepancies between what is documented in the medical record and what the patient is actually taking must be reconciled. This existence of a strong social support network in an older adult's life can frequently be the determining factor of whether the patient can remain at home or needs placement in an institution. A brief screen of social support includes taking a social history and determine who would be available to the older adults to help if they became ill. Early identification of problem with social support can help planning and timely development of resource referrals. For patients with functional impairment, the clinician should ascertain who the person has available to help with activities or daily living. Caregivers should be screened periodically for symptoms of depression or caregiver burnout and, if present, referred for additional caregiver service, counseling, or support groups. Elder mistreatment should be considered in any geriatric assessment, particularly if the patient presents with contusions, burns, bead marks, genital or rectal trauma, pressure ulcers, or malnutrition with non-clinical explanation. The financial situation of a functionally impaired older adult is important to assess. Older adults may qualify for state or local benefits depending upon their income. Older patients occasionally have other benefits such as long-term care insurance or veterans benefits that can help in paying for caregivers or prevent the need for institutionalization. Institutionalization. Goals of care. Most older adult patients who are appropriate for CGA have limited potential to return to fully healthy and independent lives. Hence, choices must be made about what outcomes are most important for them and their families. Goals of care often differ from advanced care preferences that focus on future states of health that would be acceptable, determination of surrogates to make decision and medical treatments. Generally, advanced directives are framed in the context of future deterioration in health status. Deterioration in health status. By contrast, patients' goals of care are often positive, regaining a previous health status, attending a future family event, frequently social, living at home, maintaining social activity, and functional goals assume priority over health related goals. They are also person centric and individuals. For example, regaining independent ambulation after a hip fracture may be a goal for one patient, whereas another might be content with use of a walker. Both short-term and long-range goals should be considered, and progress toward meeting these goals should be monitored, including reassessment if goals are not met within a specified time period. Approaches that have been used in CGA include goal attainment, scaling, and priorities aligned decision making. However, clinicians can establish and monitor patient goals more informally by determining this in the course of clinical care and asking about them during subsequent visits. Clinicians should be given the discussions with all patients about preferences for specific treatments while the patients still have the cognitive capacity to make this decision. These discussions should include preparation for the in-the-moment decision making, which include choosing an appropriate decision maker, appointing a durable power of attorney, also known as healthcare proxy, to serve as a surrogate in the event of personal incapacity, clarifying and articulating patients' value over time, and thinking about factors other than patients' stated preference in surrogate decision making. Medication are used to correct unpleasant symptoms. The prescription of drug depends on the intensity of specific manifestation. It is also necessary to treat chronic disease. The treatment of the pathology depends on the stage. Mild and moderate stage need treatment. Terminal stage needs the service of a 24 hours nurse, constant care and attention. However, it is almost impossible to recover. Here are preventive measures and ways of treatment. Proper nutrition. An essential part of the treatment is to ensure a good diet, since the syndrome is accompanied by rapid weight loss. Doctor prescribe a nutritious diet. Meals should be high in calories but easily digestible, and excellent choice would be sauce with meat, broth, celeries, dairy products, fresh vegetables, and fruits. A drinking regime will help to digest food thoroughly and help to avoid dehydration. Social activity, involvement in public life is essential for a feeling of self-importance. Communication is necessary for the elderly to maintain interest in life and a positive attitude. Various clubs of interest and trips to theaters, exhibition, and concerts are good ideas for being socially active. As a result, the elderly person has a positive attitude towards life and is not prone to depression. Our brain needs constant training, just like the body. Solving crosswords and intellectual game are a fun hobby and help the brain build new neural connections, develop memory, and prevent the development of asthenia. Spending time in nature positively affects circadian sleep rhythms, restores the nervous system, strengthens of the immune system, and improves the moods. Daily walk in the park or forest stabilizes pressure and relieve anxiety. Regular checkups. Experts strongly recommend doing regular checkups and consulting doctors for any alarming symptoms. The attention to of relatives. The support of family and relatives is vital and at any age, especially in old age. Therefore, for the prevention of senile asthenia, the sincere interest of relatives is important. Physical exercise. As the main symptom of asthenia associated with muscle weakness, physical exercise along with a protein diet might be a good correction of the patient's condition. According to the latest recommendation, a patient should perform exercise whenever they have spare moment. Here are four types of exercise that elderly people should do every day to prevent senile asthenia. Aerobic exercise, walking, swimming, running, or doing housework. If a patient has already begun to move, they should not stop moving for at least 10 minutes. Doing less is considered an incomplete exercise. Resistance exercise, patients need to do this twice a week. The patient may complete this exercise with dumbbell or the other trainers, but the muscles must work against resistance. Balance exercise, the simplest thing to stand on one leg, then on second. A person can perform this exercise by simply standing at the sink while washing dishes or at table while cooking. The Chinese gymnastic Tai Chi perfectly trains balance with no age contraindications. Stretching exercise. This can be elementary action. Stretch, raise your arms up to the sides and stand on your toes. It is important to do all these four group of exercise for at least 150 minutes per week. Patients suffering from severe chronic disease become even more vulnerable when asthenia progress. Support care and implementation of these above recommendations will help improve their condition. Geriatric palliative care. Patients of any age in any stage of serious illness are eligible to receive palliative care, although distinct patient population can require different approaches. As the population continues to age, provision of high-quality geriatric medicine and palliative care will become an increasingly important requirement of the healthcare system. While hospitalists remains on the front lines of providing high-quality primary palliative care, specialists geriatric palliative care requires integrating the two disciplines of geriatrics and palliative medicine in pursuit of delivering comprehensive whole person care to aging patients with serious illness and supporting their families. The unique features of caring of aging patients shape their palliative care requirements. Geriatric patients have different needs than younger patients, including an increased need for assistance with medical decision-making, increased focus on providing support to families and surrogate decision-makers, and more time and communication-intensive palliative care consultations. Geriatric patients are more likely to receive palliative care consultation for dementia, are more likely to carry a non-cancer diagnosis, and are more likely to receive a recommendation to withhold or withdraw advanced life sustaining treatments when compared to younger patients. Older patients are also more likely to have palliative care consultation for end of life needs than younger patients. Older adults have a different patterns of symptoms than younger patients, including increased frequency of anorexia, anxiety, or nausea, as well as different patterns and expression of pain. Lastly, these patients are more likely to discharge to hospice or a skilled nursing facility and less likely to discharge to home. For this reason, geriatric palliative care is a unique entity within the field of palliative care. Palliative care can take many forms and be delivered in many different settings. Regardless of settings, palliative care can be differentiated from other disciplines by the makeup of its interdisciplinary team, which includes physician, advanced practice clinicians, nurses, pharmacists, chaplains, and social workers. Hospitalized geriatric patients may interact with interdisciplinary team via consultative palliative care, dedicated inpatient palliative care units, and inpatient hospice practices. Following dismissal from the hospital, interdisciplinary teams may provide palliative care to geriatric patients in the form of outpatient clinic-based palliative care, skilled nursing facility-based palliative care, hospice, or home palliative care hospice. There is no increased attention to providing early and longitudinal palliative care with progressively increasing focus on symptom management and quality of life as illness-directed treatments become more toxic, less effective, and less concordant with patients' goals. Recent models of optimal palliative care integration emphasize referral at diagnosis, increasing presence as time progresses, and a shift in focus toward rehabilitation and survivorship care if a patient's illness trajectory improves, or toward end of life care and hospice referral if their trajectory declines. The intensity of palliative care interventions that a patient may receive is a function of unmet needs within the domains of palliative care. These needs are often independent of the intensity of a patient illness directed therapies. Palliative care can be separated into primary palliative care and specialist palliative care. Primary palliative care includes initial symptom management and routine conversation about prognosis, care goals, and code status. Areas and institutions lacking access to specialist palliative care can use primary palliative care to fulfill many of the routine needs of a seriously ill patient. In the hospital, primary palliative care is most often delivered by the hospital medicine and a geriatric team caring for the patients. Specialist palliative care focuses on advanced symptoms management and patient and family communication and as an adjunct to primary palliative care. Specialist palliative care can be delivered in a variety of ways in the hospital. The most widely available form is the hospital-based palliative care consulting models. In hospital palliative care consultation can assist with meeting the care needs while the primary hospital team continues to provide illness-directed therapy. Example of primary and specialist palliative care in hospitalized older patients. It's primary palliative care, initial treatment of cancer associated pain with short acting opioid analgesic, discussion of code status, and identification of a preferred health care agent. Specialist palliative care treatment of severe cancer associated pain with increasing dose of opioid analgesic adjuvant medication and procedural intervention. Uh, communication, navigation of complex family dynamics, and different perspectives on care goals. Preference. Physical aspect of care. One of the foundational role of the palliative care team is to provide uh, comprehensive symptom assessment in seriously ill patients and offer recommendation for treatment. Physical symptoms are often excellent predictors of hospitalization, healthcare utilization, and mortality in older adults. Pain is especially difficult to assess and manage in geriatric patients. Treatment of these patients' physical symptoms can allow for better identification of other care needs that can be addressed by their healthcare team. Palliative care consultations has been shown to improve physical symptoms management, resulting in higher care satisfaction, lower care costs, decreased length of stay, and decreased rates of re- read- readministration and ICU admission, intensive care unit admission. Robust assessment symptom is a particular challenge in older adults. The emotion symptom assessment scale is a commonly employed standardized tool that measured physical symptoms including pain, fatigue, nausea, drowsiness, appetite, dyspnea, overall well-being, and other patient-reported symptoms. It also includes measurements of depression and anxiety. Uh, these scales have been widely validated, including in hospitalized older adults with cancer. A modified these scales has been employed to assess symptom burden in geriatric outpatients with chronic illness. Unfortunately, patients with cognitive impairment may be understood by tools like ESAS, which fail to detect some symptoms in this population when compared to self and caregivers reporting. Dementia specific pain assessment are further limited by inconsistencies between tools. Specialist palliative care teams receive dedicated training in advanced symptom assessment and can assist hospitalists and geriatricians as assistant in assessing pain. Through physical symptoms are very common in older patients, little geriatric specific evidence is available to directly inform guidelines for effective and safe management. Previous studies have also demonstrated that geriatric patients experience barrier to receiving adequate pain control. Underreporting of both the presence and severity of pain seems to be a major driver of poor pain control in older adults. There is also a widespread perception that pain is a part of normal aging and not a symptom that requires assessment and management. Older patients are also less likely to receive opioids for appropriate indication, including severe cancer-associated pain. Dementia poses even greater challenges in achieving adequate analgesia as these patients experience more pain and achieve worse pain control. Clinicians are also more likely to conflate their pain with other non-pain symptoms. Assessment of nausea and vomiting in older patients can be challenging due to the high frequency of serious reversible etiologies. In this group, antiemetic choice and dosing must also be carefully considered due to increased risk of anticholinergic central nervous system and pro-arrhythmic side effects. Palliative care teams, especially trained in advanced symptoms management, can assist hospitalists in providing effective and safe treatment recommendations for older patients. Two special consideration in caring for older patients with serious illness are the geriatric syndromes or comorbidity, the presence of multiple medical diagnoses in a single patient, and variety loss of strength, function, reserve, and endurance. Older hospitalized patients with multiple medical comorbidities are at significantly higher risk of short and long-term mortality compared to their non-comorbid counterparts. Medical comorbidity predicts hospitalization in elderly patients residing in skilled facilities is associated with more and worse symptoms and correlates with decreased functional status. Similarly, frail older inpatients demonstrate poor prognosis overall, higher in-hospital mortality, a longer length of stay, and other negative outcomes, including falls, development of pressure ulcer, and development of delirium. Frailty, frailty has been identified as its own serious illness and suggested as a trigger for palliative care consultation. For these reasons, we anticipate that geriatric inpatients with comorbidity and frailty are more likely to have significant care needs amenable to palliative care improvement. Psychological and psychiatric aspects of care. In addition to treating physical symptoms like pain and nausea, palliative care team also address physiological and psychiatric problems, including mood disorders, anxiety, delirium, substance use disorders, and post-traumatic stress disorders. Many clinicians express discomfort in treating depression in patients with serious illness, in seriously ill patients, detecting psychiatric diagnosis in the context of normal grief and coping process can be challenging, resulting to underdiagnosis and undertreatment. Delirium is also extremely prevalent in hospitalization older adults with an estimate 8 to 50% of palliative care patients affected. Among specialized palliative care inpatient units and hospice, delirium is even more prevalent. Hospital delirium is associated with many complications of hospitalization, including length of stay, intensive care unit transfer, persistent cognitive impairment, and mortality. Adequate symptom assess is substantially more challenging in delirious patients. Delirium has a number of downstream effects on high-quality palliative care, as delirious episodes can cause significant patient and family distress and limit patients' ability to participate in their own medical decision making. Palliative care interdisciplinary team aid in identification and management of psychological and psychiatric needs. Palliative care clinicians regularly assess their patients for depression. Nurse-led palliative care interventions have been shown to reduce depressive symptoms in patients with cancer. Palliative care focused social workers are also trained to diagnose and intervene of psychological and psychiatric diagnosis. Chaplains who are very frequently included in or consulted by a palliative care team also provide emotional support to this patient population. Palliative care interventions such as dignity therapy have been shown to reduce depressive symptoms in hospitalized patients. In addition, the support and communication offered by palliative care team may prevent depressive symptoms. If needed, palliative care team may refer to external mental health professionals, including psychiatrists and psychologists, in order to best manage patients' emotional health concerns. Consequently, a palliative care team may be able to better address psychological and psychiatric issues which arise in the care of older hospitalized patients. The interdisciplinary palliative care team is integral to providing quality social care, while some of this care comes from physician, advanced practice clinicians, nurses, and chaplains. Social workers and are generally specifically tasked with comprehensive social evaluation, family assessment, providing counseling therapies, including cognitive behavioral therapy and dignity therapy, developing care plans that include social services, and navigating the healthcare system. Assessment and care of the family is the essential component of palliative social care. When loved ones are seriously ill, their families experience anxiety and depressive symptoms, demoralization, and anticipatory grief. Family caregivers are even in increased risk of becoming physically ill themselves. Care of the family can come from any members of the palliative and disciplinary team, but specialized intervention often fall to specific professionals like social workers. Uh, Bereavement support is a key feature of family care and is discussed in care of patient nearing the end of life below. The goals of social care intervention is to improve social support, which benefits all the patient in a variety of ways. Better social engagement is associated with better subjective well-being, quality of life, and better physical function. Conversely, older patients who experience subjective social isolation tend to suffer from increased mortality, more depressive symptoms, and increased physiological distress. New evidence also suggests that social isolation might be associated with preclinical markers of Alzheimer type dementia. Uh, spiritual religion and existing aspects of care. Delivery of spiritual care is a key role of the interdisciplinary palliative care team, and spiritual care is necessary part of geriatric palliative care. Unfortunately, an overwhelming majority of patients do not receive spiritual care even when they have a life-limiting diagnosis. Spiritual and religion health is an important factor in overall health in order patient both religious and spiritually predict social support and physical functioning and are associated with fewer depressed symptoms, better cognitive function, and improved cooperativeness. Religious activity attendance of any frequency has also been associated with decreased emotional distress. Another charge of the palliative in the disciplinary team to provide care that is aware of, respects, and aligns with a patient's cultural value. Geriatric research increasingly recognizes that aging patients' culture impact the care that they receive. In fact, age itself has been shown to be a significant contributor to patient culture, shaping both patients' cultural identities and their health care. A comprehensive palliative care assessment should include a cultural assessment for which a number of practices have been identified, including cultural respect, person-centered communication, presence and time, and discussion of what gives life meaning. Care of the patient near the end of life. One of the most widely recognized roles of the palliative care team is the providing care to patients nearing the end of life. Hospitalized patients feel that quality communication, adequate symptom management, respect and compassion, expect level care, and the respect of their care team are the most important aspect of receiving end of life care. Palliative care team assist with hospice enrollment. Patients receiving consultative palliative care in hospital demonstrate longer hospital lengths of stay. Furthermore, special palliative care involvement can facilitate advanced management techniques such as palliative sedation for refractory symptoms. Many opportunities exist for better provision of palliative care to the geriatric population. Hospitalists are often not the front line of caring for seriously ill older patients and may be an optimal connection to palliative care service. Hospital medicine clinicians are also the providers of primary palliative care, the day-to-day care of seriously ill older adults and patients with unmet palliative care needs. Consequently, it is critical for hospitalists to maintain basic skills in pain and symptom control and patient communication. Thank you for your attention.